My name is Dr. Ivan Silver. I'm the Vice President of Education at CAMH, and I'm also a geriatric psychiatrist in the PACE outpatient clinic. If you're in a general hospital or in the community, you may not attract or want to see patients with addictions because either you haven't been trained yourself to be able to treat these people, or you don't have the network or team or support to be able to do this. And I think that's a huge barrier now, that our system isn't set up for treating either addiction patients themselves or people with concurrent disorders. And what happens is the care will get split. So the psychiatrist will see the mental health aspects and refer even to another hospital to do addiction care, when that's not ideal. And that's certainly not ideal from the client's point of view or the client's family. So I think education is one aspect, and also the healthcare system isn't set up to address the very high prevalence of concurrent disorders, particularly, and of the high incidence of addictive disorders, and being able to address those clients' needs in multiple settings and not just at CAMH. I have been at CAMH for 2 years, just over 2 years, and I'm seeing different clients, different patients, with different types of problems. And so at Sunnybrook, where I was for 30 years, I could say I could put the number of fingers on my right hand up to indicate how many patients I treated with addiction disorders. And even less fingers with concurrent disorders. And here, the patients who were walking in, almost all of them have concurrent disorders, either past or present, as a significant part of their history. And this was pointed out to me early on by a patient who, when I was taking like a drug history, the patient turned to me and said, "Well, you forgot to ask me about marijuana." And this was like an 82-year-old man looking at me, and it certainly had not occurred to me. Not something in my armamentarium of history questions. And so I had to go back to the books to look at, either the language I needed to use to ask the question, to get the responses I was looking for, and people might not be willing to tell me, or even just the reminder in my history taking to ask the questions, which had been left off my roster. It's sort of like I was perhaps originally trained as a resident to at least be aware of addictions, but the sort of middle class, upper middle class population surrounding Sunnybrook was, I just didn't get to practice anything I had learned as a resident, so I lost the knowledge. So I had to gain the knowledge back here, and it was, one particular patient who pointed it out to me, and I act shocked and probably thought that was inappropriate, but nonetheless I've learned from it. So I appreciate in complex mental health patients who are living in the inner core, the concurrence of mental health and addiction problems is very high. And so we must know both the knowledge, but also have the skills to be able to treat these patients routinely. My history taking is different, and the first task is to identify patients who have a concurrent disorder. So often the referral I get from the family doctor doesn't actually include it. And it's a patient is being referred for depression or anxiety or management of their schizophrenia, but it really doesn't emphasize that they're also addicted to smoking or drinking or other substances. So I'm more deliberate in going through a checklist in identifying. I don't think, as yet, the geriatric service has fully developed a concurrent disorders like infrastructure and either a team that's actually prepared or trained well to deal with these patients, even here at CAMH. So we can always refer to the addiction services, but I believe there's only really one geriatric psychiatrist who's identified addictions as a major area of their interest. And so some of my colleagues are referring to this doctor either for advice or care. And I'm trying with my few concurrent disorder patients that I do have to try to manage these patients like on my own, but with help from advice from the addictions doctors. So there was, I had an experience last year where a patient who had an alcohol abuse problem wanted to be withdrawn. So I arranged for an admission through the medical withdrawal unit. Patient was successfully withdrawn and is now back as my outpatient and has been able to maintain abstinence for the last 2 months. So that was a very successful admission, but in a highly motivated patient who we didn't push it when he came to see me initially. We waited until he was ready. And with his mental health worker from the community, we worked together to arrange this. But when he was ready, your service was ready because it was an admission in 2 days. It was seamless. And now he's back out in the community, and I'm managing his mental health and addiction problems. Well, I think if you're going to practice psychiatry that matters, that is, you're going to get, I would say, like down and dirty, but treating the complex mental health problems that the community needs to be treated, you must be trained in addiction psychiatry. It's mandatory. You're not going to be able to do your job, and you're not going to be able to do the best for your patients unless you have that set of skills in your armamentarium. You also need to develop your network. So if addictions isn't your main interest, you need to have enough skills to be able to identify the problems and to be very knowledgeable about the system in which care is provided, how to refer, who to call, and what other members of your team, whether you're in private practice or in a hospital setting, you can call upon to help address the comorbid problems that addicted patients have as well, with housing, with their finances, with their families, and to have the proper network. So being able to learn while you're a resident, working with a mental health care team that's comfortable and skillful at dealing with concurrent disordered patients, and knowing where those teams are, and maybe yourself choosing to work on a team like that as your principal career choice. So I am a very strong proponent of psychiatrists choosing careers that are challenging and are not and are what society needs. And to me, that's addressing the mental health care needs of patients with complex disorders, with concurrent disorders, homeless population, poor people, people who really need our help. We spend a lot of money, government does too, to train folks, and it should be psychiatrists who take on the most complicated patients, and other mental health workers can do the more straightforward or routine kinds of mental health care. But I think, we're really obligated to do the most meaningful and important work, and to take care of the patients that really need us.